with all of you these last 2 years, and love to start with this quote that education is learning what you didn't even know you didn't know. So just a great way to start the kickoff. One thing that's important to know is that you are going to be able to have access to not only today's presentation, but any of our previous presentations, all the way going back to the beginning of 2025. So there's two ways to access that very easily. You can go to this website here, and that will take you to the YouTube page. Or if you're really comfortable with QR codes, you can also click on this with your camera on your phone and it will take you directly. Everything is labeled, so you'll be able to see who the presenter is and what the topic is. But we welcome you to visit those at any time that's convenient for you. And it's also great, even if you're present today, but you want to go back and revisit something you heard. It's just a great opportunity to do that. Just to let you know what's coming up for the remainder of the year, we've got a lot of amazing presenters scheduled all the way through the end of December, including our 6th annual Brain Health Symposium, October 17th. That's on a Saturday, and registration will be opening up for that next week. So hope to see many of you take advantage of that. And then I want to go ahead and just welcome today's presenter, Sherri Siegel. We're so excited to have you join us in regards to frontal lobe dementia. Between Sherri and then Dr. Desai, they provided some wonderful handouts. I've been trying to share those handouts with you just in preparation for today's presentation. But if you miss them, no worries. I will also make sure that I share them with you again after today's presentation so that you have access to them. So I'm going to stop sharing here for a moment. That way it allows Sherri to get her presentation up. And then also to have the opportunity, Sherri, either you or if Dr. Desai would like to introduce yourself.
Hi, I'm Sherri.
Why don't you introduce yourself? Hello.
Hi, welcome everyone. Couple disclosures. I was telling Mary, this is not my specialty. I'm going to give an overview of frontal temporal dementias. You can do a lot deeper dive. Some of the handouts that Dr. Desai sent have much more information on them. I'm going to keep it pretty simple and hopefully it'll work because I have never presented on a Zoom call. So Mary was also kindly helped show me how to do that. And I also have Emily, who's a caregiver of a patient of ours with frontal temporal dementia. So thanks so much, Emily, for joining us. I'm sure you have lots of good things to share. Let's see. So what is FTD? It's a group of disorders caused by, oh, can I move that over? Which normally happen in occurs at a younger age compared to Alzheimer's. It's the leading form of early onset dementia. Although the range of onset ranges from 21 to 80, although the majority of FTD cases occur between 45 and 64. Therefore, FTD's economic impact on families is substantially greater than that imposed by Alzheimer's. It's also a very rare but underdiagnosed disease that affects 60,000 plus in the US alone, and it's frequently misdiagnosed as Alzheimer's, Parkinson's disease, or a psychiatric condition like depression. On average, it takes about 3 to 6 years to get an accurate diagnosis. So the various kinds are the behavioral variant, marked by significant behavioral personality changes, apathy, empathy, and socially inappropriate behavior. This is frequently misdiagnosed as depression, bipolar disorder, schizophrenia, OCD, personality disorder, or late life disorders. The next one is primary progressive aphasia. This is language-led decline involving effort speech, word comprehension loss, impaired naming, impaired repetition, or word finding difficult. And this is frequently misdiagnosed as a stroke, depression, Alzheimer's, hearing impairment, or primary psychiatric communication difficulty. I don't know a lot about this non-fluent agrammatic variant, but my understanding is that's also a speech issue. So these other two, the semantic variant is also a loss of words, and then this primary progressive aphasia. So what are the symptoms with the behavioral type of frontal temporal dementia? It can be inappropriate social behavior, loss of empathy and interpersonal skills, apathy or emotional withdrawal, compulsive or repetitive behaviors, hyperorality, which is dietary changes and overeating. They said that the acronym for signs and symptoms is DEAR, Heidi: disinhibition, empathy loss, apathy, ritualistic, compulsive, stereotypic behaviors, hyperorality, executive dysfunction, and dietary changes, unusual eating patterns, and loss of insight. The cognitive and language symptoms are difficulty with planning, organizing, and judgment, rigid or inflexible thinking, difficulty finding words or naming things, again, primary progressive aphasia. So the primary progressive aphasias are the non-fluent, which is characterized by hesitant, effortful speech, apraxia, stuttering, etc. The semantic variant of PPA is characterized by impaired confrontation naming, impaired word comprehension, reduced object or person knowledge, poor naming. And the logopenic variant of PPA is characterized by impaired single word retrieval, impaired repetition, and slow speech with sound errors. So what do they think causes frontal temporal dementia? So it's caused by the shrinking of the frontal temporal lobes, accumulation of abnormal protein, p-tau or TDP43 in brain cells, genetic factors play a significant role in a minority of cases. So it says that FTD accounts for approximately 5% of all dementias, but represents a disproportionate share of younger onset dementia, including roughly 20% of dementias beginning before age 65 and even higher proportion before age 60. Again, typical onset is age 45 to 65. That's that. So approximately 40% of patients have a positive family history, and 10% to 20% have an autosomal dominant genetic cause. The C9ORF72, the chromosome 9 open reading frame 72 expansion is the most common autosomal dominant cause of behavioral FTD and is strongly associated with ALS and FTD, ALS overlap, and psychiatric symptoms. There's also some other genetic things that I don't know a whole lot about, but maybe if you have more questions, maybe Dr. Desai understand them more. They're also in the handouts. One was called MAPT and the other one was GRN. These are just different gene disorders that can result in FTD. So right now we don't have any single test to tests for this. It's usually clinical, listening to people's what's happening, getting history from family members. We can do the FTD PET, which can be helpful as you can see which parts of the brain are shrinking. There's also some new things on the horizon, like everything, that people are looking to do more blood testing to see if they are able to earlier diagnose FTD. So MRI or CT scans to look for atrophy, and FTG PET scans to measure brain metabolism. This is probably the number one that we do in this clinic is or the FTG PET. And neuropsych testing can also be very helpful in diagnosing this. There's no cure currently exists and no way to slow progression, although we know that lifestyle can slow the progression of any dementias, staying physically active, socially active, treating hearing loss, getting good sleep, and eating a healthy diet has been proven to slow progression in all dementias. So we focus on that a lot. If you have the PPA, which is the primary progressive aphasia, we can order speech therapy for that. A lot of it is, again, caregiver support, because this can be very difficult for caregivers. Sometimes medications like SSRIs can be helpful to manage behavioral symptoms. Again, speech therapy for PPA, and focus on symptom management and quality of life. There's extremely high burden on families due to severe personality changes. Support groups are very helpful. Safety planning, as patients may lose awareness of safety risks. All of things that we can help with in our clinic because we have a social worker and we work as a team to make sure that the caregivers are well supported and that they have access to whatever resources are available in the community. I just put this in here. There's so FTD is getting a lot more publicities, if that's the right word, now that that's what Bruce Willis is experiencing. And his wife wrote this book, The Unexpected Journey. I actually heard her speak at a conference last year and she was great. And she said that the hardest thing for her was being judged as a caregiver about the decisions she was making for her family and her husband and her kids and how they live their life. And that was very difficult. That's why she decided to write this book. So I think that can be really helpful. And then, so again, there's no cure for FTD. Experimental treatments to slow or stop disease progression are currently in trials, while a growing number of interventions are available to help manage FTD symptoms and maximize quality of life. The progression of behavioral, language, and/or movement-related symptoms varies by individual, and as the disease progresses, persons with FTD experience increasing difficulty in understanding and communicating with others or relating to loved ones. These deficits cause problems in social and/or occupational functioning that results in an increasing dependency on caregivers. Families should work quickly to identify a team of knowledgeable professionals who can help with coordinating care and the legal and financial issues. Over time, FTD predisposes individuals to physical complications such as pneumonia, infections, and fall injuries. The average life expectancy is 7 to 13 years after the start of symptoms, and the most common cause of death is pneumonia. I think once I finish, we can share some of the other websites that might be helpful. I think I have those up too. Maybe let's share that one. Hold on. I'm going to share this other website that Dr. Kuntz just showed me. So this is a fairly new website that has put a lot of really good information on it. The FTLDA, Frontal Temporal Lobular Degeneration Association. They have lots and lots of information. A lot of what I talked about, I got from this website, the overview, what is FTLD, discussing it, types of FTD, signs and symptoms. It goes in specifically to PPS. And there's caregiver support. And this is where I was reading about, there's a whole section here about what are the ABCs, possible symptoms that could clue you in that something was happening. So really good stuff on this website. And I know I saw that stuff about, oh yeah, and here's about Bruce Willis and his story and how this is helping to spread the word about frontal temporal dementia, because it's way lesser known and gets a lot less publicity than Alzheimer's currently. But unfortunately, when a big star gets it, then it gets a lot more attention and written about and on the news. And so for better or worse, at least it's getting more attention now. Does anybody, that was just my quick overview. Questions, thoughts? What else did you want to share, Dr. Desai? I know you sent me a lot of information.
No, this is great. I think before we go to the question and answers, let's learn from Emily.
Yes, let's hear from Emily what her journey's been like. And thanks again for participating, Emily. Appreciate that.
Sure. So my name is Emily Sukan. My husband, Brent, was diagnosed with unspecified dementia back in 2016. He was 44 years old. He had had several months of unexplained cognitive decline. And initially, it was treated as a mental health issue. One of his presenting symptoms was he was having some delusional thoughts and a lot of psychiatric symptoms. And so naturally, a 44-year-old person, no medical provider thought, oh, you have dementia. So we started on a mental health path. When that didn't go anywhere, we ended up getting a brain scan, which showed atrophy, but his is unusual. He does have that C9orf72 mutation that Sherri mentioned earlier. And that one actually causes the atrophy to show up on the scan in the occipital lobe, which is not where you would expect it. This is frontotemporal dementia. You would think it would be in those areas, and that's not where it showed up. That created just a whole different rabbit trail series because that didn't make any sense. And so FTD wasn't really on the forefront of anybody's minds. We ended up going to University of Utah to get a more specific diagnosis, and it took 2 years. And he was eventually diagnosed with BV-FTD. And honestly, I think because he's a really slow progressor, if he had not taken the genetic testing, I don't think we would have a diagnosis even now, because he fits a lot of the symptoms, but everybody expected that the progression would be faster. We're 10 years down this road and he's still pretty functional. And so I was asked to share some things that as a caregiver, I think might be helpful for other caregivers. So the first thing is you can't do this alone. You have to find some support. And for us, especially early on, that was just boots on the ground. So we had friends and family and even neighbors who stepped in. Brent had to stop driving and stop working. I'm still working. At the time, our daughter was a 3rd grader. We had just moved her to a new school where we had to provide the transportation. And so it was really, really helpful to have neighbors and friends step up and give rides. And we were able at that time to have Brent volunteer some places so he could keep feeling like he had some purpose. But again, it took coordinated effort from other people to help provide transportation to get him there and get him home. And then the other thing, another thing with that was we needed to get him off of all of the financial accounts. As you can imagine, somebody who has poor executive function should not be managing money. And we had some really good longtime guy friends through our church community who really stepped up and spoke with him and said, you need to do this for your family. And I think without the pressure from them, I don't know if he would have been as willing. So that was really helpful. And then the other support thing that I've personally found very helpful is an online support group. Since FTD is really rare, it's hard to find people locally who can understand what you're going through. And I think early on, I was participating in a support group through one of the local nursing homes. But because Alzheimer's is so prevalent, the advice and support that they tried to offer wasn't really helpful because his issue is not memory. I can't just redirect and he'll forget about it. He's very much going to remember and be stuck on doing the same thing. So finding support online has been really, really helpful. Another part of it that is essential is self-care. It's a long journey, or it can be a long journey, and you have to find ways to recharge your own batteries. The saying that you hear a lot is like on an airplane, they say, put your own oxygen mask on first, and it's absolutely true. One of the things with this that's hard is I have to be the one to change. He's not going to change. So if there's a behavior that's problematic, I have to alter the way that I do things. A lot of times that's just like altering my attitude. Instead of expecting him to do things, I have learned to be grateful when he does something. It's a pleasant surprise instead of a constant frustration that he's not doing it. But because I'm always the one giving and giving and giving, I have to be able to find ways to recharge my own batteries. And so for me, that's things like getting support from the forum that I'm on, but also just taking the dog for a walk, getting out of the house. I'm fortunate that I'm able to still work, so that gives me an outlet, so I'm not with him all day long. And then also just silly things like doing a jigsaw puzzle. That's something I enjoy. It's quiet. I can feel like I'm accomplishing something. But in order to do that, I've had to like outsource some things. So like I hire someone to mow my lawn and I hire someone to clean my house. And that way it carves out time for me to be able to do things that I enjoy. And then the last thing that I have found to be really helpful is just embracing a good enough mentality. I know Sherri mentioned things like mental stimulation and good diet and exercise are all really helpful. The reality is Brent is not going to do that. He's very, very apathetic. And so for me to be fighting with him over, you need to get up, you need to move, it's just a waste of my effort and energy. So it's not a battle that's worth fighting. So I just look at it and say, well, he's sitting all day and he's looking at a screen, and that's not ideal, but it's really not hurting anything. And that allows me to go to work and he doesn't get into trouble. And so good enough. Another example of that is he eats like frozen microwavable meals. Not the ideal health perspective, right? But it means he's not using the oven, he's not using the stovetop. I don't have to worry about him starting a fire in the house. And he gets some calories in his belly. So I just make sure that I make a better dinner and make that available to him. And if he eats it, great. And if not, I did the best I could. That's good enough. Another thing he does is, because of the apathy, he only showers like once a week. He used to shower when he would volunteer, which was nice, but we're down to he will shower one day a week, Sunday morning. That's all I get. So I just try to do things to alter it. Like I buy deodorant for him that's supposed to last for 72 hours. So at least we don't have stink going on. He won't brush his teeth, but he has just recently started gargling. So, hey, that's better than nothing. It's good enough. You just have to pick your battles and decide that you're not going to get perfect. You're just going to have to aim for the best you can do and let that be good enough.
Thanks, Emily. That was great. Both you and Sherri have given a lot of great information, insights, guidance. Emily, I'll ask you a question, but it's okay to say pass. Can you share your thoughts on like talking to the physician, nurse practitioners about uh, goals of care or, end of life care?
One of the things I really appreciate, we see Dr. Kuntz and Sherri sometimes. One of the things I really appreciate is that Dr. Kuntz always carves out time so that I can speak to her individually, because some of these things are hard to talk about in front of him. Like end of life care, for example, that's very insensitive to try to have that conversation when he's sitting right there. And then the other thing is like with the behavioral problems, he is, he's by nature, he's a pretty quiet and gentle guy. But because he loses inhibition with this disease, he can get a little scary. And so he's on the full dose of an SSRI, and we've added memantine to try to help with mood stabilization. But that's another place where like having that one-on-one time with her to be able to say, yeah, he's getting scary. It's just, I can speak a lot more freely. And so I think that's one aspect of it that I find very helpful.
Thank you. Thank you. Sherri, any thoughts you have about end of life care discussions?
Well, I always start really early with those conversations in this clinic, no matter what the diagnosis is, because I think the sooner you start talking about it, that these diseases are fatal diseases. I mean, they do progress and they are fatal, whether it's frontal temporal, whether it's Lewy body, whether it's Alzheimer's, they are, fatal diseases in the end. And so I think the sooner that you start talking about end of life and what that looks like and how, hospice can be helpful, I think the better it is if you start early. And, I usually say to people when I'm talking to the caregivers, like if you were having this conversation with your husband, 15 years ago when he was fine, and you said when you're in your 60s, this is where your life is going to be, how aggressive do you think they would want you to be with their care? So I think that's a good gauge, because it's really hard. It's very hard to talk about end of life and, not being overly aggressive or not, utilizing a lot of healthcare, because frequent interactions with the healthcare system can cause these diseases to progress quicker, because being in the hospital is like a new drug. So kind of talking through that, and we look at our patients with cognitive issues, in a palliative care way, like what's going to be the most helpful, how are we going to manage the symptoms, how are we going to support the caregivers, how are we going to prevent, things like falls, infections, so that we're not going back and forth to the hospital, because that just seems to help the disease progress quicker. And also always talking about hospice and how hospice can have a big role in end of life, because that's a very scary word for most people. Hospice, they think, despite the hospice has been around for a very long time now, people's perception, I find, is still that if you get hospice, you're like dying, like now, like you're in the active dying process. And that is so far from the truth. It was really, and came to fruition to keep people out of the hospital, help them have symptom support, caregiver support, and lead their best life for as long as possible. And there's still, which just is interesting to me, that still after all these years, there's still all those misconceptions about what hospice is. So I like to talk about it really early if there's an opportunity to do so, because then I think it makes it easier when they start to see the changes to know that that's going to be the right team to help their loved one live their best life and for them to get the support they need. So as you can tell, I'm very passionate about end of life care. I've done a lot of hospice, a lot of palliative care. So that's kind of where I've got that skill set. So I just, try to prepare people for what might be coming and what things would cause disease progression to occur quicker, so that they're prepared for that. Because, knowledge is is key, right? If you don't know what's out there, how you can help, you don't even know what questions to ask.
Excellent, excellent. Thank you, Sherri. So